A very good afternoon to you all. We are today going to deal with a very important topic, which we actually come across in our day-to-day practice, either as an intensivist or an anesthesiologist both. Now, why is this particular topic so important? Traumatic brain injury is a major health problem, and incidence in our country is like 1.5 to 2 millions per year. The mortality rate is also high, and how to kind of decrease this mortality when the patient is shifted to the ICU pre-operatively itself, and how to kind of decrease the problems intraoperatively also is a major concern in decreasing the death rate in these patients. The leading causes of traumatic brain injury include road traffic accidents, which we hardly can avoid actually. It could be falls, especially in children, or assaults, which are very many, which we already have. We always read it in the newspapers that we have a lot of assaults and homicides which are happening, and due to which the rate of traumatic brain injury is high. So this panel discussion on traumatic brain injury includes the panelists Dr. Malati Panchawagh, Dr. Hemangi Karnik, and Dr. Kondwilkar. Ma'am, now, we have already heard about from the stalwarts in neuroanesthesia, Dr. Karnik and Dr. Kondwilkar, and Dr. Malati is the younger of the lot. Malati is an extremely pleasant personality, and what she appears to me as an extremely intelligent student she must have been. And the way she behaves in the OT with the patient, I have seen it personally. The patient first remembers the anesthetist and then the surgeon. She is presently a senior consultant anesthesiologist in the perioperative physician at the Sahyadri Super Speciality Hospital, and she also works in the M.J. Joshi Memorial Hospital. Earlier, she was working with the Dinanath Mangeshkar Hospital, where she was majorly doing a lot of orthopedic surgery. Her major achievements are that she has been invited at various state and national conferences and even international conferences to speak on neuroanesthesia and regional anesthesia, has multiple posters and papers to her credit. One of her very good article was awareness of blood transfusion among nurses in the tertiary care setup. And it was actually published in one of the very prestigious journal, a very highly indexed journal. So now the other speaker, Dr. Hemangi Karnik, has already been introduced. She has so many feathers in her cap. And Dr. Bharati Kondwilkar, she's a teacher of teachers. Actually, all of us know her as juniors, and she really does not need any introduction. We have already heard her massive experience on neuroanesthesia. So now let us move on to the panel discussion. And the first question will go to Malati Panchawagh, the second to Madam Karnik, and the third one to Kondwilkar ma'am. So now, as we already said, that our incidence of traumatic brain injury is so high, and it's not only the brain which is affected, but it is also the other systems are involved. So what are the effects of traumatic brain injury on the brain and the CNS itself, Malati?
Yeah, hi, and thank you, Pragnya. I'm really honored to share this panel with Karnik Madam and Kondwilkar Madam. Both of them being doyens and great academicians. I will try and bring a little practical aspect to management of traumatic brain injury. And so I'll try and make this more interesting for people who are practitioners rather than academicians. So the effect of traumatic brain injury itself is a very great spectrum. It includes from mild concussion at the mild end of the spectrum to a very severe neuronal injury leading to possibly death. What it really means is that there is an external physical force which has led to either axonal injury or has led to a contusion or has led to a hematoma or any such problem, either in the supratentorial or in the infratentorial compartment, which has led to disruption of the neuronal system. this itself actually leads to either hematoma, a vasogenic problem which will occur there, or there is ischemia and necrosis of the neurons. So traumatic brain injuries can basically be divided as the primary injury which is the one which causes the brain to dysfunction, and secondary effects of the primary injury. So it's like an umbra and a penumbra that are occurring. So both of these can lead to very deleterious consequences depending on the extent to which and the speed and the type of injury which has occurred.
As a secondary effect on the brain, the other organ systems are also affected. Karnik ma'am, could you just throw a light on this? Ma'am, you need to unmute.
The brain being brain, it affects all the body organ systems because it basically controls every other system. Some of the system effects are well known to all of us, like when the patient is having severe head injury, the hypertension or tachycardia as well as bradycardia is very commonplace and we all know about it. But besides that, there are several cardiovascular changes as well, like there will be several arrhythmias which are possible in the brain injury patients. In fact, while looking after the trauma ward, I have seen all the types of arrhythmias in the severe traumatic brain injury. It can also cause cardiomyopathy. In LV dysfunction is also known with severe head injury patients. Respiratory system also, there will be some sort of neurogenic pulmonary edema, pneumonitis, respiratory irregularities. All those things are also known and we are dealing with it day in and day out. But besides that, there are other systems which are also affected and quite often they are either missed or underdiagnosed. Are the systems which are endocrine systems. There are in the acute phase, there can be adrenal hypofunction, thyroid hypofunction. There can be ADH abnormalities, and you can see that diabetes insipidus or cerebral salt-wasting syndrome or SIADH, any of these are possible. Even later phase also there can be GH and other abnormal endocrine function can be seen. One important thing is the coagulation system also gets affected, and it's very common that we have seen the large contusion patient developing coagulation defects because the tissue factor or thromboplastin is released into the circulation, leading to the coagulation cascade, and then relatively or secondary thrombocytopenia and the clotting factor defects are also commonly seen. Besides that, there are GI changes and hypermetabolic state requiring more energy requirement. Gastric ulcers are common, hyper as well as hyponatremia, those things are also common, and almost every system, even the renal functions are also getting affected, and secondary renal dysfunction is also seen. So practically when patient comes with a head injury, we need to identify and deal with every other organ system. Thank you.
It becomes a multi-systemic disease and you cannot just look at the brain. Now, this is one question which is so important for an anesthesiologist, because anesthesiologists, even if they are not manning the intensive care unit, will be called in this situation. And this situation is a little different from other difficult airway situations, which Madam has already told in her lecture. So what are the guidelines for intubation in traumatic brain injury? At what point do you intubate? How to intubate, and what are the challenges therein? Ma'am, please unmute. Yes, ma'am.
Few things I would like to highlight regarding this aspect of injury. There are so many myths about intubation in these patients. The most important thing, as soon as you receive the patient, That picture are very nice. And some people accident the patient has fallen down and had the skin sustained with traumatic brain injury or any other cause that will get the skin. Okay. Another at the time of injury, some blood and all that has to be seen.
There's a little bit of a problem in your audio. Is there another mobile phone close by which is on or something, ma'am? You can keep it at a distance.
Okay, okay. Is that okay now?
Yes, yes.
Mobile is right. So the decision to intubate to be visualized rather than
Recording in progress.
times. The guidelines are there to discriminate the decision, but that decision have to be deviated sometimes.
Ma'am, again, you're not very audible. When you said, am I audible? That was the best.
Hello?
Yes, ma'am. Yes.
Can you hear me now?
Yes, ma'am. Yes.
Okay. The guidelines describe that anybody who has got a poor distress score should be intubated. But then that is a very big term. Okay. There are in between cases also. They may not be still maintaining the airway or they may have difficulty in maintaining the airway because they are intoxicated. They are aspirated. Okay. Or they have this thing cervical spine injury by which they will not be able to maintain the thing, their position so that the airway remains vacant. So it is not only the GCS scale of 8 and 8 but all these patients who have these problems and if we are monitoring states that is okay, they are not maintaining saturation. If you have the listing, it is there and it is connected to your past vein circulation, what is the ATC2, then you know retaining the listing, it is retaining the carbon dioxide, is not maintaining. So in all the situation, the intubation has to be considered. How to intubate? Again, most important in severe traumatic injury and lungs, or maybe in a moderate and there could be some cervical spine injury. So that will have at least the clinical judgment that the patient has got some cervical, or you have to assume that he has, and therefore I have to take due precaution that we won't do a lot of movement in this patient and into the patient. Not everybody will not have the all gadgets available this thing because you have to avoid hypoxia and hypercarbia. These two distinct factors which are very, very distinct, detrimental on the distinct civilian, ICF and all that building dynamics. So how to integrate that always consider. This I have instructed everybody that whether cervical spine injury or no injury, intubate this patient if you require with the manual line stabilization. Okay. Consider this patient, they have the full stomach and they need to take precaution. And of course, those who are below 8, you don't require anything. And if they already survived this kind of injury, the prevention of hypoxia is much more important than doing some manual displacement of this thing is important. So, these are the considerations. Okay? The guidelines will keep changing day and day, but these are the key factors that I have usually considered. They are most important factors to consider the intubation from an injury or
Yeah, so the take-home message is you need to oxygenate the patient, come what may. Don't worry of the slight rise in ICT which may occur during the process. Worry about the cervical spine, but worry about the oxygen as well. So now back to Malati. As we all know, we are worried about the ICP in all these patients, whether they are in the ICU or whether they are in the OT. So what are the techniques to decrease the ICP in the ICU particularly?
So,
Yeah.
So it's similar to what we have been taught in the operation theater. Of course, there are certain things which are different. When you first get the patient in the intensive care unit, probably the patient is already intubated and probably has a cervical collar. So the first thing that one has to check is that the cervical collar is placed well and that there is no compression caused by the cervical collar, because you need to see that the jugular venous drainage is. And somehow there's an echo. One sec. Can you hear me?
Yeah, I can hear you well.
There is some problem here. Can you hear me now?
Yeah, I can. Yeah.
Right. So the thing is, checking the cervical collar, giving a propped up position, these are very important to ensure that there is good venous drainage. Like Madam Kondwilkar explained, 80% of the intracranial pressure or the volume is contributed by the brain and nearly 8 to 12% by the blood. So the blood, almost 8% is from the venous drainage. So ensuring adequate venous drainage is very important. Maintaining blood pressure is equally important because that gives the arterial flow, and preventing hypertension as well as hypotension, both are important to maintain. Like we know, ICP is dependent on the arterial flow, the venous drainage, and the brain volume that is there. So any increase in any of these components is going to cause increased ICP. So maintaining good oxygenation, preventing hypercarbia, preventing hypocarbia, maintaining good blood volume, euvolemic, not hyperhydrating the patient. These are also very important to keep the ICP in check. Similarly, and ensuring that the patient has good analgesia, because an agitated patient who is having a lot of pain has worse hemodynamics, as well as it tends to increase the intracranial pressure. So maintaining good analgesia and giving seizure prophylaxis. Seizing patient is also likely to have higher intracranial pressure. Other than this, of course, using osmotic diuretics like mannitol. So there are multiple tiers. There are different ways or different tiers in which we use diuretics. First of all, we try to use mannitol as indicated. And if we think that mannitol is working well, then that alone should be sufficient. We use varying doses depending on the situation and the hemodynamics of the patient. 0.25 gram to nearly up to 2 gram per kilo. There is a very wide variation, and depending on the blood volume status, one has to be careful. The second would be hypertonic saline, and generally Lasix is avoided unless there is some other indication to use a third diuretic. So like we said, maintaining intracranial pressure or reducing intracranial pressure cannot be seen all on its own. It has to be seen with respect to the rest of the hemodynamics and how the rest of the organ systems are also functioning.
Yeah, so it is again a multifactorial thing, and maintaining ICP to a particular, we cannot say whether it should be below a particular level or above a particular level. It has to be as per case, and it has to be at the optimum, right? Now, when and why does ICP rise in traumatic brain injury, and why should a normal ICP be maintained? Like I say, I cannot decrease the ICP, let it be. So is it right? Karnik ma'am.
Actually, Kondwilkar madam has expertly explained this, that why and how the ICP increases. Cranium is a closed cavity and containing the brain, blood, and the CSF. And because it has the fixed volume, there cannot be any extra volume coming, no space for the extra volume to come in the say. So whenever there is some increase in volume of any of this, something has to go out. Usually in traumatic brain injury, we are talking about the hematoma. That's an extra new place coming, a new segment coming in. So initially there is some compensation because of CSF from the intracranial portion going out into the spinal space, and also to some extent venous blood comes out of the cranial cavity. So initially, as the hematoma forms, there is no change in ICP. The patient tolerates the increase in volume. When the further hematoma expands, there is no more compensation possible, and because of that, slowly the ICP keeps increasing. And even if there is a slight increase in the volume, there will be sudden increase in ICP. So somewhat at one particular critical point, if the volume increases beyond that, there will be sudden rise in ICP. And that is what we are trying to prevent by using these different techniques to reducing. As far as whether we should maintain a normal ICP or no, I wouldn't call it as a normal ICP, slightly above that level, but definitely below the critical level, we try to maintain it. If we don't maintain it below that particular level, sudden rise in ICP will be there, then there will be a lot of resistance to the blood supply going into the brain. So effectively, it will cause initially focal ischemia and then the global ischemia. So the cerebral perfusion pressure will get affected. Brain will not get adequate blood, and there will be secondary changes or secondary injury also contained. Not only that, if the hematoma or the rise in ICP is restricted to one particular compartment, say supratentorial one side, then it can have herniation syndromes. Wherever the rise ICP is there, it can cause initially midline shift or herniation across the falx or the uncle herniation or anything. It tries to go, the brain will try to go into the other compartment, and that herniation can be catastrophic. If there is a global rise in ICP, then there can be coning. The whole medulla can come down and there can be immediate catastrophe. So that is why, to prevent herniation and to maintain the normal blood supply, or at least critical amount of blood supply, the ICP needs to be maintained. If not normal, slightly at a higher level. You can have your own cutoffs like 20 or 25 or whatever. Thank you.
Thank you, ma'am. Kondwilkar ma'am, does a bulging brain intraoperatively always mean that there is a rise in ICT, or there could be something else? Like we often we try to decrease the ICP, but the bulging brain still persists. So what could be the reason? Ma'am, unmute. Yes, ma'am.
As far as I know, that there is a lot of confusion amongst many people. Raised ICP means brain edema, but that is not so. Raised ICP may be a very transient process. Even if you see in the subsequent brain, there is a transient rise in the distinct intracranial pressure, and that subsides on its own within some time. Okay, so it is not necessarily that raised ICP means bulging brain. The brain may be there, may not be bulging. The bulging brain edema implies that there is a shift of fluid from one compartment to the other compartment. Now, once this cranial cavity is open and the villi is open, that I described earlier, there is no meaning for ICP. The ICP is equal to atmospheric pressure. So you cannot talk in terms of raised ICP when the brain is open. It is only this thing can be described or can be described or treated when the device closed. Okay. So bulging brain intraoperatively means the brain was already edematous and now it is popping out. Okay. So that is the situation. Now that popping out brain edema is there, because it is causing compression of the other compartment, one compartment, and now since now the space is available, it is taken out of the cranial cavity. So that's what clinically we see. So we always say, brain is bulging, brain is bulging. But what is the ICP? The ICP is not there. Okay? Now, there could be a situation where there is no brain edema. The tumor is growing slowly and there is no brain edema, or there could be very minimal edema and incorporated and ICP is also not very critically raised, and then you open up video. Okay? And suddenly you find the brain starts bulging. That means there is something which has happened acutely, acute catastrophe. And that acute catastrophe, remember, underline whatever it is, that the surgeon has done something. It is from the surgical side that is happening. That is what it is. There is some visual vessel, this brain has been populated. For brain, remember that more than the arterial system, the venous brain is extremely important. Extremely important.
Yes.
The enlargement is there, there are a lot of things that are happening which are crucial for the brain unit. So, any missing major brain which is being formulated, you will see that the brain starts bulging. Or if he has been handling unnecessary areas which is not supposed to be seen, that a lot of handling of the brain tissue also. So these two situations are totally different. Now, ICP may raise, let me explain that ICP may be increased intraoperatively, sorry, preoperatively, because the growing brain tumor has not grown to a critical level, and the patient may be just showing some clinical signs and symptoms of this anxiety, like speakers, and then some these things. But you will definitely see that brain edema on radiological. This is called radiological edema. The patient may not be very clearly single. So it's better to see on the X-ray or something whether the patient has got a radiological imaging edema. So ICP raising an edema is different. And the pros and cons of that sometimes acute edema, acute brain edema that develops because of some mishandling or profuse bleeding or combination of the brain inoperative. They are very difficult situation to manage. Even if you give mandatory in this situation, what does mandatory do? Mandatory does not it acts on the normal tissue. Okay, and it tries to shrink that area. Okay, because of the osmotic cooling. It doesn't really work on the human tissue or the tissue. It acts on the normal tissue. In that case, it shrinks that area. So try and making some space for that developing area. That is the distinct principle of doing mandatory in these cases. Demandatory. But the actual listing treatment for these cases, giving the listing mannitol, it is very temporary. But the actual listing is that debulk that hematoma or tumor as soon as possible with minimal handling of the normal tissue. Thereby, you can really help reducing the edema.
Okay.
Contrary situation is there in the head injury, because the head injury, the development of hematoma is very sudden. Profuse bleeding, intracranial bleeding, there is subrectal bleeding. Okay, so there is the same development of pathology on a different level, acute setting. Whereas in a tumor situation, this setting is very slow growing, or it may go worse once the capacity of the usual box is lost. Phenomenon of compensation happens very fast, and therefore your ICP starts rising.
Yes. So basically, it even depends on the etiology of the particular disease regarding how to control the brain bulge, besides the rise in the ICP per se.
So that is why it is important for the anesthetist to have a look at the X-ray scan and see whether the patient has any signs of missing brain edema, which is radiologically evident, and you have to take a due precaution in all the maneuvers, laryngoscopy, and whatnot, which will elicit a severe response and will increase further rise in the ICP and will initiate the brain edema if it is found there.
Okay, ma'am. Thank you, ma'am. Now coming to Malati, what is the importance of cerebral perfusion pressure, and how do we achieve a target CPP? We have various concepts about how much the MAP should be. We have a concept known as the Lund's cursor, which says that maybe you underhydrate the patient and keep a lower ICP. The other Rosner's concept says that you keep a patient at a higher mean arterial pressure, so kind of a permissive hypertension. So what is your understanding on this?
Yeah, so basically, the thing is, all of us tend to talk so much about ICP should be less than 10, 20 to 25, or the CPP has to be 60, 65, 70. Actually, practically, when you start anesthetizing such patients or managing such patients, and very, very few of us and very few institutes actually have monitors which measure the ICP. Very few of us have intraventricular catheters. All that we are left to is monitoring very simple things which give an indirect reflection of what the situation is likely to be within the brain. And that is what we've got to go by. So coming back to your question, is cerebral perfusion pressure is mean arterial pressure minus ICP, right? So keeping the MAP high and keeping the ICP low is what is going to keep your CPP good. That means cerebral perfusion going to be good. So does that mean that having a very high MAP and having a very low ICP is going to be good for the brain? No, not necessarily. Having overperfusion can also be deleterious. So maintaining a good balance. That's why there is no single answer to this question. It again has to be seen as a whole, because the patient already has, like I said, there is a primary injury, there are secondary injuries, rest of the body. If there is polytrauma, the rest of the organs are also likely to be affected. So there is no single answer to this. But having said that, trying to maintain a MAP of at least 80 to 90 and an ICP which is reasonably okay is ideal for the brain. But again, based on based on what you think is normal and what you think is a euvolemic patient or having adequate blood pressure, adequately ventilated patient, if you feel that his neurology is deteriorating, you have to rely on other factors which are giving you indirect indicators of whether the perfusion is good or not. So you got to up titrate or down titrate whatever therapy you're instituting to see whether this is actually working for the patient. Because very few of us in big institutes, we have access to intraventricular catheters or maybe other kinds. I know of only 2 places in entire India which have triple bolts and such devices. Most of us work in places where you are left to fend with regular monitors, and these are indirect indicators, and the patient's clinical situation itself should tell you whether the perfusion is adequate or not. So theoretically, 60, maintaining a CPP of 60 is supposed to be enough. There is no need to go overboard and keeping MAP very high. But again, in certain situations, so we are now talking about traumatic brain injury, but again, if there is the blood-brain barrier is reached, if there is hematoma or if there is hemorrhage, you cannot keep the MAP high because the hematoma is going to increase, and the hematoma increasing is again further going to, so it can be bad for the patient. So there is no single answer to this. So you have to decide this based on the situation that is there.
Now coming to Karnik ma'am, there is a controversy about role of steroids in traumatic brain injury as well as an SOL. What is your take on this, ma'am, and your experience as a neuroanesthetist?
To answer this question in one word, there is no role of steroids, means no. There is no role of steroids in traumatic brain injury. In fact, it has been associated, the evidence proves that the use of steroids in traumatic brain injury has been associated with higher rate of mortality. So the Brain Trauma Foundation guidelines, which have come several years ago, specifically say that use of steroid in traumatic brain injury is contraindicated. In fact, this is the only guideline coming from the traumatic brain injury, which is a level 1 guideline. And steroids are not recommended for TBI. But you did mention about the tumor surgeries, I mean tumors and all. And in those, definitely we are using steroids and the use of DEXA pre-operatively as well as during the surgery and all has a role in significantly reducing the edema, and that is why it is useful. Even some people are using DEXA even in traumatic brain injury, but it is absolutely not indicated. Thanks.
So traumatic brain injury, steroid is a no-no. Intraoperatively for an SOL, yes.
Yes.
Now coming to Bharati ma'am, when should mannitol be given in a case of TBI, either in the ICU or the operation theatre, and what are the pros and cons? Like we give mannitol, but we don't know when to start it, when we should stop it, how much we should give, should we overdo on our doses, because the surgeon is saying that the brain is bulging. So just a little, I mean, if you could elaborate on this concept. Ma'am, you need to unmute and then mute again after you're done.
Mannitol very favorite drug of anesthetists and surgeons. But if you see the guidelines, recent guidelines, it has very clearly mentioned that mannitol should be given until you have a fair idea, a good idea of ICP. That's a recent description of the guideline. Now, of course, in Western countries, they have the ICP catheters and monitors and stuff monitoring right at the beginning. But here, we do not have that facility even sometimes in ICU. Okay? So now to convert that scenario into clinical situation, okay, how do I judge whether the patient has got this ICU or not? It's my clinical sense. And my radiological reading that the patient has what is for is whether the mannitol is going to help him or is not going to help him. So, having said that, if I am definitely sure that the ICP is definitely raised, on the critical levels of raised ICP and alignment is still ICP described by several people. Some say it is about 20, some say it is about 25. Now, we always take the cutoff line 20. Okay, the normal margin is 10 or below 10. So, if I see that, okay, ICC, even on the radiological imaging, is clear this ICC is there, and we can't measure it, I will translate that into a term that it's a rate ICC. And then I have to discuss that my patient is going to have the ill effects of that race ICC. Initiating mannitol therapy decreasing the rate. Now, mannitol therapy has to be repeated after 6 to 8 hours. And it has not acted or it has not some effect on that, that does not mean we can do more. Though she has said that recommended 0.25 to 1.5 grams per kg, the patient become over to you see the effect of mannitol. So we can say half an hour's time. And that does not mean we half an hour's time. But I will keep on you have to get the exercise time for the mannitol to resolve its action. If it's not helping this mannitol action, that is something else you have to do. Or we just say that ICP patients with a brain injury. Therefore, mannitol has to be mannitol repeatedly, it's a misnomer. Okay, sometimes it is not even required, or sometimes you will get even the mannitol during the transit when the patient comes to your hospital and immediately takes it in 3 hours. Does it mean that you do the mannitol because now is in hospital? No. If you have a definite history that you have some pre-hospital treatment, patient has been given mannitol, okay, he has not improved or this is present status, he need not improve the mannitol. As soon as possible, try and see that you surgically remove the trauma, and you surgically remove whatever is inside there. Or to request activities compulsory distantly remove the request patch. So the other missing line of treatment required to be taken with the mannitol is in a shorter period of time. That is what we see as a risk. The pros and cons of this thing repeated mannitol therapy is ineffective. It has to be given at regular intervals not in a very high dose, not chronically, if it is not helping. Nowadays, they say that instead of marathon, hyperosmolar using like 0.3% of the distance would, sorry, saline would be better than marathon therapy. So some institutions are using hypertonic saline in the recommended level. So these are the listing, this is the taking message regarding marathon therapies. And sometimes putting what of this thing harm the patient rather than the patient. Possibly we could have analysis. And so many other things that I think I described in my lecture. Be careful when doing marathon. It depends on where do you meet the patient first. Whether the patient is brought to the ICU to stabilize and then taken to the.
Ma'am, may I interrupt? Madam, there is a lot of background sound, which is probably some echo coming from your side, and we are not able to hear you well because of that.
Now you can hear?
Yeah, we can hear you, but that echo keeps coming in, and so I mean, you're giving us so many inputs, and we are not able to hear it.
Madam, if you are using earphone,
Huh?
if you are using earphone, just remove that earphone.
Shall I? Okay.
Yeah.
Now? Hello? Can you hear me now?
We can hear you, ma'am, but intermittently that echo keeps coming in. You don't have any other device which is on, right? On the Anaesthesia TV or on the Zoom?
I'm logged into the Zoom only. What do you want?
No, only on one device, right? Now the echo has gone. You can continue like this, ma'am. Yeah.
Nobody is making any noise at home.
No, nobody is making a noise at home, ma'am. It's that echo which is coming. No, not a noise outside.
A little closer to the distance.
Yes, ma'am. Ma'am, you may continue. Yeah.
Okay. So I think if you are not heard, I once again repeat that mannitol has to be given assessing the condition of ICP. That is the recent guideline given by the Indian Foundation. And they said that you measure the this thing, ICP, and then give mannitol. If it is too high, the this thing, critical level, mannitol may not be received. There is no place for this thing, the brain to swing. It is like the whole brain is ready matters. Okay. Second thing is that if the anatol is given in a pre-hospital care before it's come to you, then you need not report it immediately because the action of the mannitol is lasts for 6 hours. So ideally, it should be given in the 6 hours period, after the 6 hours period. Okay. Unnecessarily increasing the dose of mannitol from 0.25 to 50 or 2, because we can give 2 grams of this thing up to 2 grams, 2 grams. That is not a good logic. You can start with a basic dose. Instead of 0.25, you can do 0.5, but not initially only I'll do 2 grams. That's not very, very sensible logic. Another thing is that where you meet the patient first time, whether the patient is brought to the ICU to stabilize him because he may have some other issues like blood loss and some fractures are there, they may have to be immobilized and wait for the surgery, or you meet the patient directly. Because sometimes same things may be working in the ICU as well as when you are working in the OT. But depending on that, how the patient is received, whether in the ICU, and then not within the 6 hours time, it should be repeated, not in very high dose. If it is not effective, then not even repeated, having own hazards causing electrolyte imbalance and oligomelia and maybe other basic problems, which I described in the lecture. Some people are preferring to give hypertonic saline and they found good results. These are my 4 or 5 lines that I described.
Thank you, ma'am. So basically, you start with a smaller dose, give it at proper intervals and not within 6 hours, and try using hypertonic saline and don't overdo on mannitol. Now, coming to the next question to Malati, it's going to be a little bit of overlap, but what is the fluid management in traumatic brain injury and what are the principles of using various fluids? Malati, you need to unmute.
Yeah, so first of all, so let me just elaborate a little bit on what Kondwilkar madam said, is that mannitol is a double-edged sword. So using it in the right dose is most important. In cases of mild TBI, maybe just a concussion, very small amount of amnesia, and patient is otherwise conscious when he's brought to you, there is no role of mannitol. So you have to decide at the end if the CT scan is normal and is just showing you a primary concussion. There is no need. You can withhold and wait and watch and see what happens. Now, apart from this, if there is, apart from mannitol, the other IV fluids that we are thinking of are crystalloids. So crystalloids, again, we all know that they are hypotonic, hypertonic, isotonic. And to maintain good intracranial pressure and to maintain good osmolality, it is essential to use isotonic fluids rather than hypotonic. Ringer used to be very popular, but before, maybe 20, 25 years ago, because it was a balanced electrolyte solution. But using Ringer is a slightly hypotonic and is likely to increase brain edema, and therefore it is not a fluid of choice. The fluid of choice is normal saline, and we can add electrolytes as necessary based on the electrolyte disturbances or the basic electrolyte panel that we have got of the patient. Using starches, again, if there is a disruption in the blood-brain barrier, using starches can be dangerous for the patient because they tend to go out and they tend to pull fluid and they tend to increase the brain swelling and brain edema. So starches is not something that is a go-to fluid initially. Then the fourth is using blood and blood products. Using blood is essential if the hemoglobin has dropped, if patient has polytrauma. And albumin is not something that we use regularly to maintain the oncotic pressure. But in chronic cases, if the parenteral nutrition is not good, for some reason the enteral nutrition is not working well and the patient is having low oncotic pressures, a small amount of albumin can be considered, but not in the acute setting.
Yes, and thank you, Malati. Now moving on to Karnik madam. Another controversial part. Now, many of us think that dextrose should not be used at all. And because it will cause a rise in the blood sugar, may not be hyperglycemia, just a normal rise in blood sugar, and it could be detrimental. Ma'am, what is your take on this? And how obviously we are not okay with hypoglycemia as well. So what should be our blood sugar control and whether dextrose should be given or not?
I'm glad you have asked me this because I like this question. First, as you said, we are absolutely not okay with hypoglycemia. Brain cannot store glucose and brain is dependent on continuous supply of glucose coming from the circulation, and that is why hypoglycemia should never be allowed to happen. And continuous blood means adequate blood supply containing at least normal level of glucose is essential. So that has to be monitored and ensure that glucose is being delivered to the brain. One thing. As far as the dextrose containing fluids are concerned, dextrose containing fluid, meaning if we say 5% dextrose, then as Dr. Malati said, that it becomes a hypotonic. It increases edema, cerebral edema. So it is a big no. As far as the isotonic fluid with addition of dextrose is concerned, so that the patient continues to get adequate glucose, there is no specific contraindication per se. To deliver glucose to the brain, dextrose can be added when needed, but blood sugar should be properly monitored. Why do we have this hesitation that the dextrose should not be given to the brain? If there is cerebral, if there is hypoxia, and if there is lot of circulating dextrose available, then what will happen? If there is no hypoxia, glucose is available, glucose will be metabolized properly into the mitochondria and Krebs cycle, through the Krebs cycle and all, and enough energy will be produced. However, if the glucose is available, lot of glucose is available and oxygen is not available, then only pyruvate will be formed. The proper complete metabolism will not take place because there is no oxygen. And then there will be pyruvate will be converted into lactate and there will be excess of lactate. Now this excess of lactate is going to be harmful to the brain cells. And that is why if there is no oxygen but more of glucose, then it will be more harmful to the brain. And that is why that condition should be avoided. So if there is any focal hypoxia or global hypoxia, then having a higher blood sugar is bad for the brain. As far as the general glucose is concerned, if the oxygen supply and oxygen delivery is adequate, giving a normal dextrose is an essential item rather than a necessity, rather than a luxury or a bad thing. I have seen that when people are being told that in traumatic brain injury, glucose containing fluid should not be given, but blood sugar should be monitored, what happens? That should not be given happens very easily and is properly followed, but the monitoring, blood sugar monitoring at a frequent interval is not happening. And I have seen pregnant patients, 9-month full-term pregnant patients, not being given any glucose for 4 days, GCS going down. And then suddenly when we find it, then we find the patient in hypoglycemia, then have to given, and the bolus has been given and the patient becomes all right again and all. Such things should be avoided. Always ensure that there is adequate glucose level maintained. If required, give dextrose containing fluid. If we are not giving it, ensure that there is no hypoglycemia occurring. Usually we try and maintain around 110 to 140 milligram percentage rather than having it too low or too high. Thank you.
Test is going down, you have to rule out hypoglycemia before thinking it's a deterioration of the traumatic brain injury event.
Yes.
Now coming back to Kondwilkar ma'am. Ma'am, please unmute. What electrolyte imbalance is seen in traumatic brain injury and what is the role of magnesium in TBI?
I'll just take a liberty of continuing this discussion. That there's again a misconception about this fluid. Glucose containing fluid and fluid for maintenance and glucose for caloric building. There are two different things are there. So many a times the students they ask me, why not do 5%? Okay, that 5% dextrose is going to be into the water and going to add to the. And then as she very rightly put it that we have to avoid hypoglycemia as well as hyperglycemia. And over a period of time, there could be a catabolic state where the patient will have a lot of this metabolic changes. So you have to supplement and this. I used to use always this thing, a slow infusion of 10% glucose, depending on what is the blood glucose of that patient. Of course, blood glucose monitoring is very, very essential. It is one of the very important tool to guide you regarding the patient's progress under anesthesia and post-operative. So that was my comment on addition to your disease. Coming to the electrolyte imbalance in traumatic brain injury, as I have described the brain edema that occurs in traumatic brain injury is a vasovagal. Okay. And wherein there is a lot of there is a loss of sodium potassium pump. And the entry of this electrolyte is imbalance of sodium potassium distinct. So you might see hyponatremia or hyponatremia in these cases. That will come to know only when you use electrolytes. And that has to be again checked time and again. If there is a hyponatremia, sometimes the patient cannot have any other element which is hyponatremia or hyponatremia is going down and is level of consciousness. As far as you ask me the role of magnesium, people have advocated magnesium, but it has no definite role. Magnesium has several distinct characteristics. The first one is that it has an anti-inflammatory or some analgesic property. Beyond that, it has not major role that has been described, and its use again is controversial. It has a definite role in your summer and night arrangement. There is a basis present. Hello?
Yes, ma'am. Yes. Ma'am, now you are better heard and the background noise is slightly better, less, what I mean. So hyponatremia is seen in these cases, and that is something which you want to bring back to normal. And we have said that you have already said that there is a role of hypertonic saline both to control the sodium levels as well as to control the colloid osmotic pressure. So, and regarding magnesium, yes, there is a role in terms of anti-inflammatory action which magnesium has. Now, going back to Malati.
Pragnya, can I just add a couple of things there with your leave?
Of course, ma'am, you can.
So like, Karnik madam spoke about dextrose and the presence of oxygen or the absence of oxygen. One of the newer methods of measuring what's happening at the brain level is to make a burr hole and introduce a microdialysis catheter, which is of course still in the experimental stage, but in very advanced, like 2-3 years ago when I was in Stanford, they were using this microdialysis catheter in their ICU. And what they did was they checked the ratio between lactate and pyruvate. So they send flushing fluid and pick up the extracellular fluid from the brain. It's sort of filtered. That's why it's called a microdialysis catheter. And they check the ratio between the lactate and pyruvate. So they try and analyze what is happening in the tissue fluid. We are talking about hypoxia at the PaO2 level. But what's happening to the oxygen in the brain? What is happening to the fluids, or what are the electrolyte components within the extracellular fluid in the brain? That is what is being analyzed, and that's where you can give targeted pharmacotherapy. So whether to give adequate glucose or not. So this is at that level that people are, of course, it's not possible for us in our scenario, but I just wanted to give a sort of backup to what she was trying to say about using the right amount of glucose. And yeah, sorry.
Ma'am?
No, it has also relation with the blood supply, and LP ratio is usually used to ensure that whether the blood supply, cerebral perfusion is adequate or no, and mainly that is put in the penumbra area, and also the focal ischemia can also be quantified, and then you can give according to that. But yes, that's a very good measure. Unfortunately, even after the 15 years, it has still remained in the experimental stage only and has not found a common place in the practice. Yeah.
It's very expensive. Even for them, it's very expensive. It's only when they have grants for specific conditions they are able to use it. Otherwise, they're also not able to use it regularly.
Yeah, when I had been to the same institute, they were not using earlier. Yeah.
Thank you, Karnik ma'am. Now moving on to Dr. Malati. What are the ventilatory strategies in head trauma? Now, there have been pros and cons of using PEEP as well. Like on one side, there may be improvement in oxygenation. In the other side, you may have an effect on the arterial blood pressure. So what is your take on this?
So I think the first thing is when to institute ventilation. It again depends on the GCS of the patient, the Glasgow Coma Scale. Anything less than 9 certainly needs to be ventilated. 9 to 12 is a gray zone where you have to decide based on other things whether ventilation is necessary or not. If the patient is not able to maintain airway, it's a very clear-cut case where ventilation needs to be instituted. What kind of ventilation needs to be instituted again depends on what the patient's trigger is and whether there is other kind of injury. Mostly we try and give complete mechanical ventilation without paralyzing the patient. Initially for intubation, maybe paralysis may be used, but later on, try not to use any paralyzing agent. And with adequate amount of sedation, you can maintain volume controlled ventilation. Again, here the strategy is to avoid volume trauma, try to reduce the amount of the tidal volume that is being used, try not to hyperventilate the patient. And an interesting thing is inspiratory pressure, peak inspiratory pressure, as well as the expiratory pressure. The peak inspiratory pressure again should not be high, because the peak inspiratory pressure also reflects on the intrathoracic pressure. The higher the intrathoracic pressure, the lower will be the venous drainage, and that will also increase the intracranial pressure. Similarly with the PEEP, increasing PEEP also increases the intrathoracic pressure and reduces the venous drainage. But again, having some amount of PEEP is essential. Now, what is some amount of PEEP? 5 to 6 centimeter water is a good amount of PEEP that needs to be used to prevent atelectasis, because we will be using oxygen at higher levels than normal, and prevention of atelectasis, patient lying down on on his back most of the time. This is very essential to keep the lungs open and to have alveolar recruitment. PEEP of 5 to 7 is not adequate to, or it's not high enough to prevent venous drainage. Again, higher amounts of PEEP are essential to get across enough oxygen or to remove carbon dioxide, which are also going to be detrimental. So PEEP alone cannot be, you cannot say don't use PEEP or use a lot of PEEP. This again has to be seen in the light of the other metabolic and hemodynamics that are happening with the patient. Second thing is, it also depends on the compliance of the lung. What we have seen is that if you have normal lungs, if you have otherwise ASA grade 1 patients who have not aspirated or who do not have chest injury, or for some reason have good airway pressures and good lung compliances, then higher amount of PEEP is going to be more dangerous for the patient. But if patient has an acute lung injury or has pleural effusion or polytrauma or a hemothorax or has neurogenic pulmonary edema, or for some other reason a pre-existing condition which leads to poorer lung compliance, higher amount of PEEP is good, because you are able to get across enough oxygen and to remove enough carbon dioxide, which is necessary to keep the ICP normal. Having said this, in any kind of lung condition, a PEEP of more than about, I think 14, 15 should not be continued for a prolonged period of time. Maybe short periods of time, this can be given. PEEP again is essential. Most of these patients have tracheostomy, or even in intubated patients, you might want to do suctioning. So before and after suctioning, that is when you need to institute for short periods of time. So like it has been the theme throughout from the morning, that everything has to be customized. There is no, not at all, or sometimes. So this again depends on the clinical situation. And that's why experience and knowledge is very important to know when to institute what maneuver.
Yes. Thank you, Malati. So optimization of PEEP as per the condition of the patient is important. There is no blanket rule on this. Now, regarding intraoperative hyperventilation, right throughout the residency, honestly speaking, Karnik ma'am, we have been hyperventilating the patient. And then as we grew, we got to know that there are several cons to it and not only the pros. So could you throw some light on this?
Just a moment. Before I go on to the intraoperative hyperventilation, I would like to add a few words about the PEEP. Dr.
Yes.
Malati very well told about the pulmonary compliance and the high compliance during the chest trauma and all. About the cerebral ICP also, if the intracranial compliance is also varying when there is a raised ICP. So in a normal patient, the PEEP, the way PEEP will affect the ICP and all, normal ICP, it will increase the normal ICP the same way the PEEP does not increase the higher ICP. Say a normal ICP may increase by 5 if PEEP is instituted. Similarly, if the patient's ICP is already 30, then it will not go to 35 or something like that, because the brain is less compliant. So the PEEP becomes less effective or less detrimental when the ICP is high. Having said that, another thing is we are getting a lot of polytrauma, as she mentioned. And quite often, PEEP is essential to correct the hypoxia. If you provide PEEP, correct the hypoxia, then as she said, the ICP will actually improve. So PEEP is good, but the optimum PEEP should be used. And I just want to mention the ceiling to it. The ceiling level is up to 12 has been proven to be acceptable, provided no hemodynamic changes are taking place. So if you can maintain the blood pressure at the same level with PEEP, instituting PEEP up to 12 level, it has been proven in the literature that it can be safely given in the patients of head injury. Coming back to the intraoperative hyperventilation, yes, as Madam mentioned, the earlier guidelines by the Brain Trauma Foundation, the second guidelines, did mention that if the patient is rapidly deteriorating and we need to control the ICP fast till the patient is decompressed, then probably a transient hyperventilation was allowed. It was recommended so that quickly we can control the ICP and the surgeon can quickly decompress and all. However, this provision of a short-term hyperventilation also has been taken away in the third guidelines, the third edition of the Brain Trauma Foundation guidelines. Now, hypertension is not recommended. A normal ventilation or normocarbia is recommended because any hyperventilation is associated with the vasoconstriction and therefore reduced cerebral perfusion, cerebral blood flow and perfusion pressure. Now, where does this vasoconstriction take place? That is another interesting aspect. Okay, if we hypoventilate, there will be vasodilatation, there will be adequate blood supply and things on. But when we hyperventilate, which part of the brain gets the vasoconstriction, normal or abnormal? Quite often the abnormal brain might have lost the CO2 reactivity, but the normal brain is going to react to that hyperventilation by vasoconstriction, and it is the normal brain which certainly will get less blood supply if we hyperventilate. So it is the normal brain which is more at risk of ischemia when we are hyperventilating. So this is a big issue where hyperventilation can cause the secondary secondary brain injury and make the normal brain, the normal uninjured brain at risk. And I have seen the global infarcts also secondary to the prolonged hyperventilation. So that is a big problem and it should not be used. What will happen to the affected side? Probably if the CO2 vasoreactivity is normal, it will also have the same thing. Vasoconstriction will take place. That area also will get further low blood supply. If it is already affected and it is impaired, probably there won't be any effect on the effect of hyperventilation. So in that case, what will happen? That the normal affected brain, affected or abnormal brain will keep on getting the normal blood supply even when you are hyperventilating, and normal brain will get less blood supply. So if there is a midline shift, it will actually get accentuated. So we have to be extremely careful about this and avoid such thing. What we are trying to do is probably preventing coning and all, and what is actually happening is something different only, that midline shift gets accentuated and things like that. So probably it would not be a good idea to give even intraoperative hyperventilation, but having said that, still many people are using it for a transient time till the surgeon can decompress the brain, just in the hope that less than 30 minutes, the brain will tolerate that much hyperventilation and the coning can be prevented. However, this is removed from the guidelines and not to be used.
So use of transient hyperventilation and maintaining a lower CO2 in a situation where there is a lot of brain edema is an okay for a small period of time. Otherwise, we keep the EtCO2 levels at around 30 and to 35, and that should be enough for the particular patient, whether it is a head trauma in the ICU or in the operation theater.
Yeah, but the transient hyperventilation also is removed from the recommendations.
Yes. Now coming to ma'am, she's already told us actually about hypertonic saline in patients and when to use them. But what are the drawbacks of using hypertonic saline?
Okay, I would like to have some comment on previous two this thing. My experience I want to share on this topics. So please continue. The role of PEEP, as Dr. Hemangi described, up to the level of blood there are distinct recent trends or some recent literature reviewed has said that normally when we are giving ventilation, there is because of this thing that there's an autoclave that is to the amount of 5 centimeters of water. So giving PEEP of 5 to 7 is of any no use. It is as good as not giving PEEP. But all you want to give PEEP, that is that when number has come. Okay, you do that 20 to 15 minutes. Now in a long term, that PEEP of that also is not good to help because as Dr. Hemangi described that the ICP is really at the level of 30. That level of 12 centimeters is not going to do any more distance that is going to remain there. And therefore, the strategies which were adopted by some workers is rather than giving, this is in the ventilatory management, rather than giving PEEP to this patient to recruit the alveoli and improve the oxygenation, when you are giving the volume support, volume control ventilation, you add some pressure support to that, very minimal. That is much more better than adding PEEP. That was one thing I wanted to add. Coming to the hyperventilation, very categorically I mentioned in my lecture that hyperventilation, although these days recently, Pharma guideline has not made any comment on that, not recommended. But whenever it was recommended, it is used as a rescue mechanism, rescue treatment for a very short period. And because you have nothing else in the hand, so you do hyperventilation and try to squeeze the constriction and try to do it as much as possible. But even if somebody continues that for a longer period of time, over say 12 hours, the literature said fatigue of hyperventilation. Fatigue of hyperventilation. That means at the end of 7 to 8 hours, that phenomena of hyperventilation, the effect of hypertension wears off automatically. And she said it is more detrimental to the normal tissue than to the affected tissue. So hyperventilation therefore has been out of the evaluation. That is it. Because it is more dangerous to have a longer than we keep continuing to the normal rate at risk, and therefore that strategy is completely out of this. Coming to my question of hypertonic saline, I think I said in the last question that this is one of the distinct hyperosmolar agent being used in many centers for treating your two advantages that the patient is on the low on the sodium side, it takes directly that. Along with that, also there is higher osmolarity of 350. Correct, after the osmolarity in the longer run, if you do hypertonic saline, you can have the imbalances. If you give it too rapidly, hypertonic saline, higher concentration, then I will report of pyrenosis after it. So this is my take on hypertonic saline. Anybody wants to add more than this?
Yeah, so we have used hypertonic saline. I will not say pretty often, but infrequently enough, especially in the operation theater situations, and occasionally before shifting the patient to the operation theater from the ICU. We give doses of 1 to 2 ml per kilo if the mannitol alone has not been sufficient, or during surgery if there is a lot of brain swelling. I haven't really seen in the last 20 years, I have not really seen pontine myelinolysis occurring because of use of hypertonic saline. Maybe others have, but that does not mean that we have to rush in and give high amount of doses. Of course, it has its negative effects and consequences of using hypertonic saline. But more important, when we are using hypertonic saline, like you mentioned, was to keep track of the metabolic acidosis. If you tend to use quite often repeated amounts of repeated doses of hypertonic saline, hyperchloremic acidosis is a very common occurrence, and it's difficult to treat and to get down frequently. In head injury patients, what we have seen is even slight amounts of hypernatremia of about 155 or so is not really that damaging. hyponatremia is certainly more damaging than hypernatremia, but again, we can err a little on the higher side of sodium as compared to going on the lower side of sodium. If the achievement of lowered ICP is what we are targeting, this again has to be seen in the context of the patient and in what situation we are using this.
Thank you, Malati. So the take home is that hyponatremia is a no-no. Keeping sodium levels at a higher level of normal is something which we should do in these traumatic brain injury patients.
Yeah,
now,
and
coming,
the
yes.
beauty of using hypertonic saline is that you can give repeated doses as well. So you can start off with maybe 50 ml. Like I said, 1 to 2 ml per kilo. You can start off with 50 ml. This is very, very useful intraoperatively. This is what we have seen. You give just small doses, 50 ml, and see the effect. The effect is fairly immediate. And you see that there is a reduction. If not, in 10 minutes, you can repeat another dose. The beauty of hypertonic saline is its repeatability. Whereas with mannitol, it's difficult to keep repeating this in, frequently.
Okay. We find that many of our head injury patients have fever. And so how can hyperthermia occur in, how does it occur in traumatic brain injury, and how does it affect the brain? This question is for Malati.
Yeah, so hyperthermia per se, there are, especially if there is a pontine hemorrhage or brainstem injury, that can itself lead to thermal temperature dysregulation, and therefore hyperthermia can occur. Hyperthermia can also be because of an intense inflammatory response that the body has instituted in response to the head injury. Just like we have immunosuppression, there can again be hyperthermia which is instituted. But more important than all of this is you have to check whether there is any secondary infection, especially in the lungs. Pneumonia is the most common reason why patients are likely to have fever.
Yes, can you hear me? Coming to Karnik, ma'am. Now, hypothermia is obviously detrimental to the brain, and hypothermia has been used earlier. So can hypothermia be used, and is it therapeutic in any way?
Yeah, hyperthermia increases the cerebral metabolic rate of oxygen, and therefore it is absolutely we need to control. But whether the opposite, hypothermia or reducing the temperature, will protect the brain or no is the big question. When it should be instituted, how long it should be continued, and all those things are the controversial subjects. There are two aspects. One is the induced hypothermia, and where we are deliberately bringing down the patient's temperature. Now, this is usually happening when the patient has very severe head injury. Patient is having means being given some sort of therapy like barbiturate coma and all. But barbiturate coma will reduce the cerebral metabolic oxygen only during the activity. The cellular activities will be can come down on cellular requirement can come down only if there is a hypothermia. So that is why this hypothermia interest was there. There were multiple studies. Some gave for 24 hours. Early onset of hypothermia given for 24 hours. Then when that didn't work, some studies came with the positive results that when you gave it up to 48 to 72 hours, it is affecting somewhere in the favorable way. And that is why for in between few years, that was found to be beneficial along with the other regular management and all. The most recent guidelines are coming from the Polar trial. And Cooper et al. Did this study in 5,000 plus patients and all those things. And then what they have done is they have started hypothermia much earlier, even in the pre-hospital phase. So before the secondary injury takes place, if you can reduce the cerebral metabolic rate of oxygen, whether that can cause any cerebral protection, whether that can affect the outcome or no. But even the results of those trials have said that at 6 months, there is no change in the outcome, the mortality and overall it remains same. So it's beneficial effect, whether it really helps or no, is still in doubt. And there is no sure shot way that whether it can be considered as the therapeutic or no. There is still doubt. Apart from that, there is something called induced hypothermia, means passive hypothermia. Instead of actively cooling the patient, whether just not warming the patient intraoperatively, whether that can be used or no in a beneficial way. And some people have found that the passive hypothermia that can occur by not warming, that instead of 37 degrees centigrade, probably at 35 or 36 patient behaves better or no. It is general observation that it helps, but there are no randomized controlled trials and proofs or anything which definitely can point out that it is helpful and it should be used. So hypothermia is still a question mark.
Yeah, while it is a question mark, if a patient with traumatic brain injury or a multiple trauma comes to you and the patient has a lower temperature, don't try to warm the patient very rapidly, because that could be detrimental. And the second thing, as you say, that before the secondary injury occurs, if we could keep the patient at a lower temperature, it could help.
Maybe.
So this is, yeah. Thank you very much, ma'am. Now coming to Kondwilkar, ma'am. Ma'am, we are giving anti-epileptics to each and every patient of traumatic brain injury, and calcium channel blockers have also been, like nimodipine, have been found to be useful in these patients. So what is your take on this, ma'am?
Recent guidelines say that prophylactic use of anti-epileptic is of no use. So if you just say that the patient has an injury, no convergence evident, and just giving phenytoin and of no use. There has to be a definite evidence of at least subclinical seizures or convulsive activity. Then you can start this thing within first 7 days. The drug of choice, they still say it's phenytoin. They have compared that drug with the newer drug, Ventilatory or something like that. But then there are no very encouraging reports, comparable reports of that drug. Although in our hospital, surgeons have been using that drug very constantly. Coming to calcium channel blocker, it has again a very specific role in cardiac hemorrhage or with the vasospasm. So unless there is a definite evidence of vasospasm, and also you can diagnose with the modalities, so vasospasm, activity of clinical engagement. The common drugs which are being used, nimodipine, nifedipine, and many more other calcium channel blockers are being used. The dose of calcium channel blocker, nimodipine, is about 60 mg. Or if you want to do it lesser, you can go for 10 to 30 mg. Role of calcium channel per se is not in general disease. There has to be evidence of vasospasm. That is why it is taken.
Basically, using anti-epileptics to up to 7 days may be an okay, but you should not go beyond that because you don't have any conclusive evidence on that. Calcium channel blockers, yes, it may help, but maybe you need to know whether there is some amount of vasospasm in the patient, and only then you move ahead on that.
Anti-epileptic, not prophylactic. Prophylactic randomly you can't give because it has no role to do. There must be definite distinct that, or there might be a distinct, but that subclinical evidence you will have only when you do the EEG monitoring. This most of it is not possible.
It is almost a protocol in the hospitals to start the patient on anti-epileptics immediately once the patient comes in. But probably there is no evidence to the use of these anti-epileptics in these patients. Now, coming to Malati again, literature states that there is a use of certain drugs like amantadine, and even progesterone helps in traumatic brain injury, and so the incidence of complications in females is said to be less. Like secondary brain injury comes in later on because progesterone is said to help in traumatic brain injury. Any take on that, Malati?
I'm not so sure about progesterone, Pragnya. At least the papers that I have read have not shown progesterone to be useful. There are, of course, studies which say this way and that way, but most of them are inconclusive, and I'm not really too sure about progesterone. But about amantadine, I have had the occasion to use it a couple of times, and certainly for a temporary period, for sure, Amantrel is what we have available. Amantrel given orally through the Ryle's tube has helped in a patient who's recovering. Their functional outcomes become better only for the period which you use. And if you continue to use it for a longer period of time, it doesn't show any improved or better outcome than not using it. So for short periods of time, when for some reason you want to know or you want to get to know what is the best response that this patient is capable of, certain times you need that. That is when amantadine helps. I'm not too sure about progesterone though. In fact, there have been some studies where even erythropoietin was used to see if using erythropoietin could carry enough, better oxygen, could give more oxygen to the tissues that needed them. And but even erythropoietin has not been proven to be useful. Does anybody else know about progesterone? I'm not too sure about that though.
Actually, literature says, again, as you said, there is no conclusive evidence on the use of either progesterone or erythropoietin. But there are studies where progesterone has been used, and in some cases, it has shown some benefit in terms of limitation in the secondary effects which occur due to traumatic brain injury. Nothing is conclusive.
Yeah, progesterone does have a cerebral protective effect, but I'm not too sure whether it influences the long-term outcome of the patient.
Yeah, no. Many of these drugs are under study, and the 6-month outcome which we talk about is not very great. Yeah.
But the only drug which is used as an adjunct and which is perhaps underutilized in head injury is tranexamic acid. It has a fantastic role to play, and it really changes. It's a game changer for many patients.
Could you throw some light on that, Malati, since you have talked about tranexamic acid?
Yeah, it limits the amount of, especially in cases of hemorrhage, like subdurals or extradurals, because it tends to cause a more sticky clot. It tends to sort of plug the rupture that is there in the vein, which has caused the bleeding, or the artery. Of course, if it's a major thing, nothing can happen there. But intraoperatively, it helps in achieving hemostasis quicker. And tranexamic acid limits the amount of hemorrhage that has occurred before the patient reaches the operation theater. So that has it has very good evidence, perhaps even level 1 evidence that it has helped in neurologic outcome, better neurologic outcome.
Thank you, Malati. Now moving to the next question.
Can I add one word about that?
Sure, ma'am. Sure, ma'am.
Yeah. About this early administration of tranexamic acid also has been positively found to be beneficial. In fact, now the CRASH 3 trial results have come out, and they have said that if it is given within first 3 hours of admission, or even before admission, within first 60 minutes of the injury, then the results are much beneficial. It is significantly reducing the size of the clot, and then that is recommended to be used. And early administration really makes the difference. The later ones, probably it may help, but early administration really helps. Up to 8 hours, the results are equivocal, but up to first 3 hours, it is definitely beneficial.
So it is for the ambulance team who actually reaches the spot. If such a situation should occur, then they can administer it on field. But if a patient has come to the hospital without having had a CT scan, then the CT scan should determine whether you are going to give tranexamic acid or not, because it's not going to be of any use in patients who have simple concussion. It's going to be useful when there is a breach in a vessel.
Yeah, the moderate to severe head injury rather than.
A little bit on neurogenic pulmonary edema and management, ma'am. Karnik, ma'am.
Initially, I did mention that brain injury affects all the systems and all, and neurogenic pulmonary edema is also one part of that. Trauma causes intense stress, and lot of sympathetic stimulation takes place, and probably as a result of that, the neurogenic pulmonary edema takes place. Quite often it takes place within 2 to 12 hours of severe, moderate to severe head injury, and up to 20% incidence in severe head injury has been noted by certain people, certain authors. Severe sympathetic outflow can probably lead to the pooling of the blood into the pulmonary circulation, which is relatively having lesser resistance. Even contributing factors are considered as severe sympathetic spasm or overflow can lead to myocardial ischemia, or it also increases the capillary permeability, and that is why this pulmonary edema develops. The clinical picture is the same as what we see in the other pulmonary edema, the frothy sputum and the hypoxia, usually associated with the hypertension and all. And as far as its management is concerned, it is usually symptomatic. Of course, it is happening because of the severely raised ICP. So the ICP correction is the mainstay of the management. Apart from that, we may have to give the positive pressure ventilation. If there is hypoxia, additional supplemental oxygenation, and appropriate ICU care. The PEEP pressure monitoring and ICP monitoring does help over here. And other management that has been proven to be helpful is using nitric oxide. If the patient has already developed ARDS type of picture, then our management, ventilatory management and the other management will be typically same as the ARDS. So accordingly, that needs to be managed. Usually controlling ICP reverses or reduces the severity of it. That is what we have seen.
Thank you, ma'am.
Yeah, I would like to add just one small point here is the FiO2 that we give. You know, there was an occasion when somebody who visited our ICU had told us that don't give too high FiO2s in patients who have head injury and even if they have pulmonary edema. While that is true, you have to adjust the FiO2 to target your PaO2, especially when there is pulmonary edema of neurogenic origin or of whatever origin. Achieving good PaO2 is essential to achieve a good amount of oxygenation in the brain. So you adjust and titrate your FiO2, if necessary, even higher FiO2s to get adequate arterial oxygenation. That is important in this setting. It is just to add on, you know, some people may have some confusion about not using too high FiO2s, but that again, that has to be targeted for our effect.
Yes, Malati, you're absolutely right. Like from the outset itself, we have said, right from the part where you want to intubate the patient, what is most important is giving adequate oxygen to the brain. And then you do not have to worry about so many other factors which may come into play. Now, coming to the effect of anesthetic agents on the ICP, you have already told us, ma'am, in detail, but I would like to know which are the agents which you have been using and what is the role of newer agents like desflurane?
Okay. At the outset, I said I have not used desflurane much, but one thing is very sure that it causes hypertension, and I was sure that quality and characteristic does add to the ICP. Coming to the classification of the anesthetic agent, the other agents used, let's take the muscle relaxant with your subclinical, if you are using still, it does cause ICP rise constantly and comes back. But it may be detrimental in the patient who are already have high ICP. So in such patient, it is better to avoid, but if it has to be used for some reason that we are anticipating you want to integrate, then we may access that by and large for some time. Muscle relaxants are not known to cause any rise in the ICP unless there is a hypoventilation. So it is not a muscle relaxant, it is a hypoventilation causing hypothermia. Other drugs that I have been using, that I have used was spectrum of drug with my 30 years of analysis. I'm trying to use the fan and then switch over to propofol, even I had a study on midazolam history and pandemic luxury trials. So amongst this, of course, propofol supposed to be a more favorable drug in terms of causing least amount of disturbances in terms of ICP. So, but if it is given for prolonged time, the impact is more than the protective drug. Barbiturates, again, if this is given, it has the same effect. And of course, beyond these drugs, I have not used this narcotic analgesics. We've been using fentanyl since long time. Before that, we have buprenorphine and Betadine. Of course, I have no experience of Betadine being used in anesthesia. And unfortunately, either buprenorphine or this. So you have to really remember that basic of anesthetic agent at this hour when I'm hungry. I remember at this point I have only 4 or 5 drugs. So the others too may add to this.
Ma'am, Karnik ma'am, Malati, could you add anything on what ma'am has already said?
Yeah, so I would like to just elaborate a little on the use of desflurane. I have used desflurane. It has been my favorite agent for maybe 15 years now. But in the head injury setting, let us say acute head injury who comes for a decompressive hemicraniotomy or a craniotomy, desflurane has no greater advantage. In fact, I would prefer not to use desflurane in that setting. Sevoflurane is certainly more stable and probably has better effects as far as the ICP and perfusion are concerned. But in a patient who has had a head injury, who has been ventilated, who is polytraumatic, who's recovering neurologically, and who is now coming for, let us say, long bone fracture fixation, or for some other reason that needs to be explored. Desflurane works wonders if you want to have a patient who's breathing well and whose urologic status you want to assess immediately after the surgery. Desflurane works well. Such people also tend to have fairly unstable hemodynamics, and you don't want to give too high a dose of anesthetic agent. They may already be on dexmedetomidine sedation. I tend to use a little bit of polypharmacy in this situation and tend to go lower down on the anesthetics. And then in such a situation, desflurane is wonderful to use, provided I'm using lesser than 1 MAC. Maybe I just use 4-5% of desflurane and combine it with small amount of dexmed or something as a supportive measure, and not give too high an anesthetic because I want the patient to be more responsive at the end of surgery. But this is different when this patient comes for, let us say, an extradural hematoma or a subdural hematoma or a decompressive craniotomy. Then sevoflurane, even isoflurane, works well enough because you've got the skull open after a particular point of time. Again, all this is depending on what dose you use. This thing is how much MAC you're using. If you're not too sure what MAC, you don't have anesthetic gas monitor, sevoflurane is the best agent to use. But if you happen to have AGM and if you happen to be in control of many other situations, then even using lower amounts of isoflurane or desflurane are okay.
Yeah, even I completely agree with Dr. Malati that our choice for the head injury is the sevoflurane that has the best cerebral dynamics. Desflurane has got slightly negative, but theoretical there is a minor difference. And we can use desflurane. However, our choice is sevoflurane, that is the best. Whenever we use either sevoflurane or desflurane, we ensure that we are using the drug in a lower concentration, usually restricting it to 1 MAC or lower. And that's what we are doing it commonly. If the patient happens to be obese and we want to recover desflurane scores, as far as clear-headed recovery is concerned. So that is what advantage. But we use commonly Sevo.
Okay, coming back to Dr. Malati, your experience on use of intraventricular catheters, if any, and how are these newer, you can say, the newer techniques, why? Because they are not really available to all of us. useful?
Yeah, so theoretically there are, invasive and non-invasive methods of monitoring ICP. There are indirect indicators of what the ICP like we've been discussing right from the beginning. And I have only used ventricular catheters. So EVD, it is the external ventricular drainage. And I think it has a great role to play when used in the right situations, because it also tends to be therapeutic, not just diagnostic. Not only does it tell you what the pressure inside the ventricle is like, but when the situation calls for it, you can even drain the CSF and reduce the ICP. So that has a double advantage of being a diagnostic as well as a therapeutic tool, as well as being very cost effective. But it again depends on what kind of ICU setting you have, what kind of theater setting you have, because in not all situations is it possible to put the EVD. Placing the ventricular catheter itself needs to have some adequate size of ventricle available. In a completely compressed brain, it's not possible to even introduce the ventricular catheter, and it has a potential to cause, hemorrhage or bleeding from the site of entry. And infection, of course, is a very major thing, and ventriculitis can be very morbid for the patient and even contribute to mortality. So using EVD has to be done if you're comfortable with it, and if your theater setting and your ICU setting allows for it to continue to be used in a sterile fashion. Pragya?
Now, since the beginning of this webinar, or this panel discussion for that matter, we have been saying that the oxygenation going to the brain is the most important. So, Karnik ma'am, could you throw some light on the role of cerebral oximetry and jugular venous oxygen saturation measurements, though we may not be using that?
Actually, we have used both at different time frames, time places, and all those things. Jugular venous oximetry is not a new technique, and that has been going on since many years and all. Usually, it tells us that how much oxygen is left after the blood has left the brain. And in 2002-03, we were putting lot of jugular venous catheters for collection of this to see whether we can do something, and it can help us in guiding the oxygen therapy or ventilation, or the improving the cerebral perfusion or so. But then the literature as well as practical experience and all was not actually helping us in guiding our therapy. So that remained as an experimental utility only. It gives us the global oxygen saturation, venous oxygen saturation. So overall global status of the brain, we come to know. As against that, the cerebral oximetry, that is NIRS based non-invasive technique, gives us the amount of oxygen that is there in the brain underneath the our sensor, wherever the sensors are placed. Commonest site is the forehead, and whatever amount of oxygen is there in that region is picked up. Of course, the proper calculations and whatever is there in the skull and the subcutaneous tissue and all is subtracted and all those things. But predominantly that also gives us the venous oxygen, predominantly the venous saturation is being told. Now, when we are talking about head injury patient or traumatic brain injury, the area that we are interested in is the penumbra area, and that is not being picked up. So whether really we can assume that a cerebral oximetry is good, so everything is hale and hearty, is not really true. What we need to measure is the oxygen going into the at-risk brain tissue needs to be monitored. So there, both these techniques become inadequate. Ideally, we should be using the invasive technique, that is the brain tissue oxygen oximetry, PBTO2 should be measured. But then that is rarely used, and I don't think any of the centers are currently using it, and whether they are finding it useful or no. None of these techniques are newer technique. They are all more than 15, 20 years old. So whether they are really useful or no, that is doubtful. The cerebral oximetry, even though it sounds popular because it is non-invasive, has not really been helpful in guiding the therapy. Having said that, both cerebral oximetry as well as jugular venous oxygen saturation is reasonably reliable indicator of brain death, or it can be used for a prognostication. So jugular venous oxygen saturation, if it is say above 85%, that means brain has not used any oxygen. That means the brain metabolism is nearly gone. Patient is brain dead. That sort of outcome assessment has been done. Cerebral oximetry is relatively better. Even it is useful to see the adequacy of the blood supply. So whenever there is a global ischemia type of situation, at that time it is more useful rather than the traumatic brain injury. Say for after cardiac surgery or the carotid artery surgery, where the blood supply is going to get significantly altered and all, where the cerebral oximetry can give us some idea whether the blood supply is coming properly or not. However, there is a grossly limitation in traumatic brain injury.
I agree, madam, that focal oxygenation or focal hypoxia is not something that you're able to pick up with this. It's more of a global cerebral indicator. And have you had the occasion to use transcranial Doppler in any situation? That seems to be quite promising and probably least invasive. And now that ultrasound is coming in a big way in anesthesia and in critical care, perhaps TCD can have a better, use.
TCD is really useful in traumatic brain injury. Also, there are promising results and all. We do have TCD, but currently it is not working and not working since a long time. So I have not had much chance of using it. I have seen it being used in other ICUs and all, and it is definitely sounding promising. Not only TCD, we can have a combination of 2 or 3 things. In fact, so much so that that has actually reduced the need for the ICP monitoring. So now rather than ICP monitoring, we are more likely to use this multiple other monitors, which tell us more about the CPP rather than the ICP monitor. Otherwise, for ICP, we have used the intraventricular catheter, we have used subdural bolts and all, but all those things a long time ago. Now we have the Codman catheter, and even the Codman has come out with other catheter that instead of the brain tissue, inserting it into the brain tissue, they can insert it into the ventricle so that you can use it only for, not only for ICP monitoring, you can also aspirate the CSF from that. So it can be used in a therapeutic way. But the cost is tremendous. The Codman catheter with this double thing is, I think, 40,000 per catheter or something. So I think that is something impractical for our population. So that's there.
Thank you so much, ma'am, for your from what you have told us regarding these oxygen monitoring equipment which is used in traumatic brain injury or in neurosurgery, both, because many of us have not actually used any of these. Now coming to the question to Dr. Kondwilkar, ma'am, regarding postoperative extubation of this patient. When do you start weaning these patients, and how important is postoperative analgesia in this patient?
Now, weaning of this patient, I'm extubating. It depends that what was the status preoperatively, what was the status after the veterinary surgery was done, and what are the distinct other diagnostic tools you telling me about this injury that the patient had. Now, patient of diffuse external injury may take very long time to improve. He may not improve also. He may succumb. But there are definite instances and definitely also patients are improving over a period of time. So such patient may require distinct postoperative medication for a very long time. And the extubation criteria for this, what is there? you have to switch off all your muscle relaxant. So, and keep them under the sedation. Whenever you want, you can reduce the level of sedation instead of your one. So, conventionally, when we see intubate or wean of our patient, we stop this muscle relaxation. We put them on a short break. You give them trials with the other modes of ventilation, like SIV or any other modes like that. In similar strategy, in our ICU, we used to use respiratory because that can be switched off and switched on easily. This will provide anesthesia solution, the patient can accept this thing very easily. You will be able to check your outcome and symptoms in this patient. So the benefit of this giving can be given only to a patient if they are neurologically improving and giving them trial of this intubation if they are maintaining their respiratory parameters. Because some patients may be having compromised this neurological outcome. They may be in a vegetative state and they may be able to maintain their respiratory and serious well. So, three criteria in such patients that they are not neurologically improved completely. That's one thing. That checklist we have to take from your surgeon, and there has to be a joint decision whether to extubate this patient now or when and at what time. And that is one thing, neurological improvement. Whether the patient has been maintaining the last 48 hours is cardiovascular stability, and what is the respiratory drive when you get on a different mode of ventilation or the criteria. There are two major criteria to is considered now. Having instrumented to the patient, you have to be always in a readiness to intubate that patient again if anything goes wrong. So therefore, it's a very wrong procedure. Over a period of time, you may take 24 hours to make that decision complete, whether to intubate or not. That's going to be one patient and a different mode of ventilation. As far as the post-operative anesthesia is concerned, post-operative anesthesia post-operatively required. But in head injury patient per se, they may not require the anesthesia for their neurological disinfecting. They may have a pain because of their craniotomy issue. Craniotomy site may give the anesthesia. But if you have used in acute setting, the scan block or even within the scan block later on at the end of the surgery, that can work for some time. You cannot keep on repeating that scan block for number of times. So we have switched over but for ventilation as well as anesthesia, expiratory works wonder. They don't need any additional. But all they require is they are completely or if there are any vital changes because of the day, then supported by paracetamol. We have definitely seen avoided recent or other narcotic analysis because that may hamper your assessment of neurological function, or they may again hamper your cardiovascular stability, again bradycardia, hypertension, and all of this. So the best combination for ventilation, sedation, and anesthesia, we have always used either respiratory. Earlier we used to use a lot of propofol. Propofol again has over a long time it has disadvantage of students. Now recently regarding the long-term ventilation in these patients, that if you have to ventilate this patient for a long time, earlier they said avoid perfusion, but recently the guidelines have very said for a long time. It is better to have the planned perfusion on these patients because it is easier to see rather than giving another common infection by keeping the tube for longer time. There are chances that this patient will block this infection in this patient. So once a tracheostomy is given to the patient in the planned fashion, the healing becomes more easy. You can evaluate your patient's respiration and other parameters very easily, and you can reinstitute this ventilation to the profession. So I think that's all about this question.
Thank you, ma'am. Ma'am, Malati ma'am or Karnik ma'am, do you want to add to this regarding post-operative analgesia especially?
Oh, I think she has covered almost everything.
I agree with what she said.
Yeah.
It is impractical to repeat blocks. Analgesia, generally, actually, these patients do not need too much analgesia if there is just head injury or for just a craniotomy. If there is polytrauma, then we have to think of other, maybe blocks or something that can be used on a continual basis or as an infusion basis. But other than that, in my experience, it's not very necessary. If you know that this patient is likely to be ventilated or, on a tube for a long period of time, then even using fentanyl patches is not a no-no, provided you have a fairly lucid patient. So these again are situations, these are gray zones, when to use what. Dexmed is an absolutely wonderful drug that has been introduced for us, and it is a lifesaver in many situations. A very small dose of dexmedetomidine has been useful. You don't need to use higher doses. If higher doses are needed for sedation, then you might need to consider using a vasopressor if you're going to use dexmed as a sedative, but not as an analgesic agent. And dexmed tends to have effect even for a much longer period of time after stopping the infusion than we think it to be, though, because probably of cumulative effect that is there. As far as weaning and extubation is concerned, what Madam said was true. If you happen to catch the patient in a lucid phase, then you can think of extubating on table. But otherwise, the question of shutting off paralytic agents, seeing his recovery, this doesn't arise. Because once the patient goes to the ICU, very rarely we use neuromuscular or paralyzing agents to keep the patient ventilated. We tend to use other agents, and you need to wean them off the sedative agents rather than the paralyzing agents. That's all that I wanted to say.
This has been a very long discussion of 2 hours on traumatic brain injury. I have a few more questions, but I think I would not like to ask them now. It has really put all my residents, doctors, and even the private practitioners, those who are working in the various institutions, as also who may not be working in neuroanesthesia on a daily basis, they have definitely benefited because of this particular discussion which we had with these stalwarts in neuroanesthesia, Dr. Kondwilkar ma'am, Dr. Hemangi Karnik ma'am, and Dr. Malati Panchawagh. Thank you so much for being here for us. I would like to extend my thanks to all of you and would like to felicitate all of you. Now, this particular felicitation is for Dr. Malati Panchawagh, who was not there earlier with us in the morning session. And as we all know, for those who have joined in late, Dr. Kondwilkar ma'am has received the A.M. Deshpande Oration Award for this year. This is the 6th time which we are giving the award. And this is generally given during the ProAct PuneCon, which we have, which is actually a huge conference which we have. It's a 2-day conference which we hold in a physical manner, but because of the COVID situation, we were not able to do it this time. And so we could not call you and actually give you the various, the hospitality of Pune, which we could have otherwise extended to all of you. We could not do that. Thank you very much, all of you all. And over to Sushma ma'am.
Society of Anesthesiologists Pune would like to take this opportunity to inaugurate our first e-bulletin. The theme being for this bulletin is obstetric anesthesia. This e-bulletin contains 3 articles. The first article is an experience shared by a smart group on a labor analgesia. The second article is a write-up by a Dr. Neha Kulkarni She narrates her experience on a successful management of a parturient presented for C-section with undiagnosed cardiomyopathy. And the third article being is the Marathi poem by Dr. Kirti Kundalwal named Prasuti Kala Banlaya Chaitanya Lahari, which depicts the experience of a would-be mother going through a labor pain and the feeling of a mother of a just born baby. So I would like to conclude the session by giving a vote of thanks. So I thank our faculty, Dr. Kondwilkar Madam, Dr. Hemangi Karnik Madam, and Dr. Malati Panchawagh Madam for their such a elaborate, extensive presentation on a very relevant topic. And this has definitely enriched our knowledge on a traumatic brain injury. I would also like to thank all the delegates who have joined with us for this webinar on a Sunday afternoon. And I would also like to extend my vote of thanks to Dr. Ashok, Shyam and Rahul Choube for giving us a huge platform for presenting this webinar. So thank you all once again and have a good day.